So first we'll see about maltoma. Normally, malt tissues are nothing but lymphoid tissues which are present outside the lymph nodes. So it is going to the GIT, it is going to be present normally in the ileum. So in ileum, you know the Peyer's patches, right? So Peyer's patches in ileum are going to be the most common site of malt tissue, the normal malt tissue I'm telling. But the most common site of maltoma, that is the lymphoma arising, will be in the stomach. Okay, so this can be asked. It is a confusing thing. So remember, malt tissue is present normally in ileum, but maltoma most common site will be a stomach. But if they ask what is the most common lymphoma occurring in a stomach, it will be DLBCL and not maltoma. Okay, so the most common lymphoma in a stomach will be diffuse large B cell lymphoma and not maltoma. But maltoma most commonly occurs in stomach. And also the most common extranodal site of lymphoma will also be again a stomach. But if the patient is a AIDS patient, so in those patients, the most common extranodal site of developing lymphoma will be the CNS. Okay, primary CNS lymphoma. Remember, that was the one of the AIDS defining cancers also. Then this H. pylori associated maltoma will have a translocation 1118, which is associated with this maltoma. Okay. 1118 translocation is associated with maltoma. Then on microscopically, maltoma will have this lymphoepithelial lesions. So these are nothing but the enterocytes are going to be invaded by the lymphoma cells, that is the lymphocytes. So the lymphoma tumor cells will invade the epithelium and they are going to cause epithelial damage. So this is what is called as a lymphoepithelial lesion, which is a classical feature we see in this maltomas. And usually maltomas are quite low grade tumors, but they can progress on to a high grade tumor like a DLBCL. Then moving on to gastric carcinomas. So gastric carcinomas, more than 90% of the cases are adenocarcinomas. And so what are the risk factors associated with gastric adenocarcinomas? So there are various pre-neoplastic conditions in this. So let's start with the normal environmental risk factors. Firstly, we are already seen H. pylori infection. So Helicobacter pylori is a risk factor for both maltoma and adenocarcinoma. Then we have nitrosamines. That again I mentioned, the entire GIT risk factor will be nitrosamines. Then obese patients, then salted and smoked foods, decrease intake of fruits, so vitamin deficiencies will be there. Then alcohol and smoking, and also gastric surgery. So for some other cause, the patient has undergone a gastric surgery. So in that, the rest of the part of the stomach which is left, so that is called as a stump. So in that you can develop a carcinoma. So undergoing some gastric surgery is again a risk factor for developing adenocarcinoma. Other than that, we have certain pre-neoplastic conditions like an adenoma. So adenoma can become an adenocarcinoma like in a colon here also, and also pernicious anemia. So pernicious anemia, I already mentioned, it was leading to vitamin B12 deficiency. So that was related to autoimmune condition wherein autoantibodies are produced against the parietal epithelial cells. Then we have a Menetrier's disease. So Menetrier's disease is a hypertrophic gastropathy actually. So we'll see about that later. So that is also a pre-neoplastic condition. Then blood group A. So blood group O was for peptic ulcer disease, whereas blood group A is for cancer. Then clinically, how will these patients present with? These patients usually present with weight loss and dyspepsia with dysphagia. And they'll also have nausea and weight loss depending upon the site. Suppose there is an antral tumor. So obviously, the food cannot pass through the stomach. So it can trigger nausea and vomiting. And the patient will have an early satiety also. So as soon as they eat food, they'll feel satiety. And it can lead to anorexia and anemia. So metastasis is common in gastric carcinomas, and usually it is to the lymph node surrounding it. So other than that, we can also have a left supraclavicular lymph node metastasis, which is given a special name called as Virchow's node. So Virchow's node is nothing but the left supraclavicular lymph node. And Sister Mary Joseph nodule is given when the periumbilical lymph nodes are being involved. And it can also metastase to bilateral ovaries through a transcoelomic spread. So transcoelomic spread, it can involve the ovaries, and there it is given the special name of Krukenberg's tumor. So what are the types of gastric adenocarcinomas? We have two types, gastric intestinal type and the diffuse type. So intestinal type, as the name suggests, it is going to appear like the intestine and it is forming glands. Okay, so glandular morphology will be there. While in a diffuse type, it is going to appear in diffuse sheets or single cells. So discohesive single cells. And here it is because of the mutation called as CDH1 mutation, which encodes for the E-cadherin. So E-cadherin mutations, where else did we read? Yes, in breast lobular carcinoma, right? So there again, this E cadherin is a cell addition molecule. So once the cell addition molecule is being lost, the cells will become discohesive. So single cell infiltration will be there, and classically their morphology will be that of a signet ring cell. So signet ring cells will have intracytoplasmic mucin, which is going to push the nucleus to a periphery, and this is going to appear like a signet ring. And since these diffusely infiltrating cells, they usually do not produce a mass. So polypodal growth kind of thing will not be there, but it will be diffusely infiltrating as single cells. So entire wall of the stomach is going to be involved, and the wall of the stomach will be quite thickened, and that is what is called as a linitus plastica. Linitus plastica literally means it is going to appear like a leather bottle. So leather bottle appearance is seen in diffuse gastric carcinoma. An intestinal type of gastric carcinoma, it is a very simple type. So it is going to produce a glandular morphology like any adenocarcinoma. And here the mutations is going to be APC beta catenin mutation. So since the name itself suggests it is intestinal. So in intestinal tumors, we are going to have beta catenin mutations. So the first trigger will be the beta catenin or APC mutation. So the same mutation will happen in this intestinal type of gastric adenocarcinoma. So it is important to test for HER2/neu in all of these GI tumors, especially the gastric tumors. So why? Because HER2/neu expression is seen to be there in some of these tumors. So if HER2/neu is positive, you can give hormonal therapy trastuzumab. Okay, so monoclonal antibody targeting this HER2/neu is trastuzumab. We can give that for treatment.